Hello and welcome to the fresh episode of Fridays with Dhawale. Our today's topic is bridging the gap between Hahnemannian principles and modern psychiatry. We'll be dealing with this topic in two parts. In first part, we'll try to understand mental state with importance and relevance of psychiatric diagnosis. We'll understand person diagnosis and correlation of disposition with modern principles in psychiatry, remedial diagnosis, and concept and importance of psychiatric formulation. In second part, we will see through the case that we'll be taking up today, the psychiatric formulation matrix, importance of formulation in problem definition, and importance of formulation in planning interventions, role of homeopathic intervention, psychotherapy, psychometric assessments, and finally we will summarize the learning. So before I start the part 1 directly, let me just bring to your attention a few important mental health related statistics. A study published in Lancet Psychiatry in 2020 says that in 2017, out of 1,300 million people in India, 197 million people had mental disorders. Out of that, 45 million people had depression, while 44 million people had anxiety. Another statistics published by Nimhan says that nearly 150 million Indians need active intervention, while less than 30 million are actually getting it. Plus, it also says that in India, there is only one psychiatrist for every 100,000 people, whereas the desirable number of psychiatrists is 3 for every 100,000 people. And that's why the topic that we have today becomes very much relevant to understand that with our existing principles of homeopathic science, how can we become the game changers if we are able to bridge the gap that we have with our principles in relation to these psychiatric principles? So let's start first through what homeopathic principles are when it comes to understanding mental diseases. So right from the lesser writing of Hahnemann, which tells you about the account of the Clockenbring case, till all the 6 editions of Organon, probably all the aphorisms are very much crucial to understand how to manage a case of even a mental health issue. But here are some highlights for you. So right from aphorism number 3 to 6, 83 to 104 and 210 to 230 talk extensively about knowledges that we require as a physician to take a case, to diagnose a case, to perceive what is wrong with the person, and importance of not just collecting the data in terms of physical complaints, but also the importance of mental state and dispositional data while we take a case. Aphorisms 7 and 9 both focus on the importance of mind body to be considered as one unit, probably the central concept in homeopathy, plus how we are going to form Hahnemannian totality, how we will identify exciting maintaining causes and remove them, and furthermore how we individualize the case, which kind of 153 aphorism talks of when it asks us to understand what are characteristic symptoms. And last but not the least, it is aphorism 210 to 230, which specifically talks about 4 types of mental diseases that Dr. Hahnemann gave based on the then knowledge systems and his experiences, where he also talks about importance of knowing mental state and mental disposition, manifestations of various mental diseases right from soma to psych and psych to soma, mental diseases which start from sudden onset and which are related to traumas and stressors in the environment, alternating states that are seen in mental diseases, and the treatment of the same with antipsychotics with similimum, as well as he lays down some important psychotherapeutic principles. So let us go ahead and see through case that how we can actually use this knowledge system and how the current advancement in psychiatry can help us to manage effectively a case of disease. So this is the case. It's a 37-year-old female who approached to me in December 2015. she approached to me with the complaints of sudden episodes of fear, anxiety, palpitation, and cold sweat all over. All the episodes started in 2002, one episode probably every week, but since 2007 and 8, it has increased significantly. Initially, it used to happen only when there were the triggers, which you can see in the form of modalities. But now, for no reason, she starts suddenly with the episodes almost probably alternate day. In 2007 and 8, she also started with the symptoms related to severe guilt, low mood, weeping, sense of helplessness, lack of enthusiasm, tiredness, body aches with similar set of modalities. Allopathic psychiatric medications were going on, but they did not help her to a significant extent, and that's where she just is off medication since last almost 2 years. Going ahead, dispositional data talks about significant craving for sweets, she being a chili patient, often constipated since childhood, past history of conversion reaction, father having hypertension, diabetes, paternal grandfather and paternal grandmother both dying due to MI, and mother having again diabetes. Menstrual history, she had complaints of PCOD. Currently, the cycles are regular, but the flow is pretty scanty. And in obstetric history, as you can say, she had spontaneous abortion and 2 pregnancies were complicated with placenta previa and gestational diabetes. Moving ahead to the significant data or highlights from her life space. So, since childhood, she was more often surrounded by her grandparents, and out of that, grandmother was extremely conservative and orthodox, was not pro female education, and she would have a lot of fights with patient's mother, who was already working as a principal in school. And those fights, after that, patient would always get some thrashing or scolding from her grandmother, apart from regular nagging. On the other hand, this grandmother was pretty normal with her brother, who was 5 years elder to her. Parents belong to very educated family, but the parenting styles they adopted were more of authoritarian and punitive. They had big dreams for the patient and brother in terms of careers, so there was a lot of academic pressure, and patient being a little laid back and weak in studies, a lot of restrictions were put on her, and constant unhealthy comparison would go on. But but her thoughts was that, okay, let me just do whatever they want to do because that is how they will love me. On the other hand, it was only the paternal grandfather from whom she received the unconditional love and support. He would appreciate and approve her of the smallest achievements. He would protect her from unnecessary scoldings and punishments. So he became her world, and he was a very crucial support system. Later on came her husband, whom she met in college. The husband was very protective and pampering, and she connected and got attached to him instantly. But when she married, her in-laws, since they were not happy with this marriage, would always criticize her. There were some financial issues for which they would constantly blame her, and all this did not really help the patient otherwise. Right now, she has 2 kids with whom she's pretty attached, and they serve as a motivation for her to get better. Some instances from her life space are pretty important. So, entire childhood went into being restricted, being constantly told up to what to do, what not to do, being constantly interfered. But she was okay with all of this because she felt that that is how she will be able to keep these people happy. In 1995, when she was 17 years old, paternal grandfather suddenly passed of MI, and she said that it was a huge vacuum. It was very difficult for her to deal with the separation, and she was practically into depression in those days as well. Somehow she came up, and by the time she was recovering from that phase, she met her future husband in college, who happened to be her senior, and she instantly identified with the husband's, he being very pampering in nature, and she said that she felt the void was completely filled, which was left after the grandfather passed away. And that's how they both began to stay together constantly. She would be very restless when he wouldn't be around or he wouldn't come to college. And so happened that in 2000, when husband relocated back to his hometown after finishing his education, patient was very insecure whether now the relationship is going to continue or no, in spite of the fact that husband would reassure that he is going to be for her and they are going to marry. Irrespective of that, she would keep spying through common friends. She would keep calling him. She would act sick, and husband would come running initially. But as he came to know that she is becoming a little clingy, he started to get irritated. In 2001, patient finished her MA English and parents asked her to work, but she was not confident of going out and really standing on her 2 feet. So just to avoid that, she enrolled in another post-graduation degree. In the meantime, the issues with the husband would just continue, making her day by day more anxious. In 2002, a husband's family suffered major business losses, and that's where the in-laws, the parents, wanted an alliance in some other business family. When patient got to know this, she was extremely insecure, and that's where the fear of abandonment set in, and she literally lied to him that she's in the early stages of her pregnancy and that they need to get married no matter what. Husband did stand by his word and he took a stand and he did get married to her. Patient covered up that lie somehow, but it did put her into a significant guilt. But again, she not having the courage to go and admit it because she thought that if it's done, then the husband is probably going to again leave her forever. That's how she came into their family, but in-laws not okay with this alliance. They would constantly blame her, criticize her, taunt her, and she was not knowing what to do. All she would do is not let husband to go to work, would constantly want him to be around, would cry, would get sick, and doctors would say there is nothing wrong with her. She would go to her family, get the husband over there. So it was very difficult for the husband to handle, and he was very much irritated by her clingy and childish behavior. In 2007, during a second pregnancy, there were 2 deaths occurring in the family because of MI, and at that time she was also diagnosed with placenta previa. With all these deaths and complications occurring around her, in the emotional vulnerability, she confessed everything that she had done till now so that the husband stays with her, and that got husband totally mad at her. After that, since then on, in fact, her panic started when husband always brings up that he repents marrying her and he should be leaving her, he should have left her long back and all of that, and that triggers the panic attacks, and multiple visits have been done, multiple ECGs have been done, but she just cannot get over it. And when she tells the husband about her anxiety symptoms, he gets mad at her, he blames her, and many times even hits her now. He wants that she should go out to work, but she doesn't feel confident. She feels she's totally incompetent to work on her own and stand on her 2 feet, and now panic attacks have furthermore aggravated the situation. So, said and done, the case was taken, and the next step is, of course, to find out the totality of the case. So, let's see the mental state of this patient. You can see that the intensity of fear and anxiety that comes up in the situations of no stress or perceived stress tells us that it's not an adaptive anxiety, but something that puts her under the spectrum of psychopathology. Right? That's why DSM-5 was referred to, and it says that the typical symptoms of fear, palpitations, cold sweat, rumination, and the episodes correspond very much to the criteria of panic disorder. Once we establish this diagnosis, it becomes easier because then we can differentiate the qualitative expressions of this anxiety spectrum, and the qualitative expressions here are the modalities which trigger or which aggravate the panic attacks, the situations and the thoughts that are there in that panic attack. So you can see reprimands, humiliation, confrontation, avoidance, all of these become the qualitative expression, or in simple words, the characteristic symptoms of this case. Similarly, if you see the other set of symptoms, that is related to mood and enthusiasm and sleep disturbed appetite, reduced, you can again refer to DSM-5, and they belong to the category of dysthymia, or what we call it as persistent depressive disorder. Similar, so again, same way, once this diagnosis is established, it becomes very easy to see what are the qualitative expressions of this case of depression. Right? So amelioration, consolation, amelioration, assurance, all these modalities become the characteristic symptoms of this case of anxiety and depression. Now, further, if we study her entire life space right from childhood in a longitudinal way, and we apply certain aspects of psychodynamic theories, certain aspects of cognitive theories of how personality develops, then we are going to understand how her mental disposition, that is, her personality, has developed. So personality ideally is defined as stable patterns or set patterns of behavior, cognition, emotion, and perceptual processes that evolve from interactions of biological and environmental factors, and that is nature versus nurture. Okay, so when there is an imbalance between the interactions, the personality that develops is usually not having healthy patterns. Rather, there are some traits which are hypertrophied and some are underdeveloped. So, when we study her case, we come across peculiar patterns wherein the behaviors are aimed at preserving relationships. She becomes subordinate to stronger people so that they don't leave her, indicating submissiveness. There is a constant fear of dark and constant fear of abandonment. Then she's attached very much, but the attachment comes from the need for steady inflow of support, because she doesn't know what she can do. She feels helpless if she doesn't have her people around. Similarly, there is significant indecisiveness. She doesn't believe that she can take decisions on her own. She needs constant assurance and validation. She is highly dependent on people around her. And then there is a poor ego development psychodynamically because of authoritarian and punitive parenting, and the self-esteem, that's why, is very low. There is a constant view that she carries that she is incompetent, she is helpless, she all alone is nothing. Right? So this is the peculiar personality that we see, and certainly this covert maladaptive patterns are somewhere responsible for even her current mental state. Right? Now all this is happening even without her knowledge. She doesn't understand that the patterns she has are actually maladaptive, and they are pretty dysfunctional. So when we again apply DSM-5, we realize that these patterns are the characteristic patterns of what we call as dependent personality disorder. Apart from that, if this becomes the understanding of her mental disposition. The physical disposition, we can see ambithermal towards chili, craving sweets, perspiration in general, chronic constipation, and scanty menses. Right? So we go ahead further. So we have the data, the characteristic data of mental state, we have the understanding of mental disposition, and we have physical disposition. So the next job is to erect the totality and find out the simillimum. Acute remedy was directly referenced from Materia Medica, considering the intense fear of death that she would experience, or the intense thought of death that would come up during that 5 minutes of panic attack. Takes us to the remedy aconite. Chronic remedy, if you see repertorization, that was done. Again, two closely running remedies were Calcarea carb and Pulsatilla. Uh, they were differentiated based on thermals, based on the disposition, and based on certain observations. Like Pulsatilla person would have been very tearful even while narrating the symptoms, but this female, she was going to tremendous anxiety while narrating the symptoms. She also said that if she is even thinking of those symptoms to tell me, she's getting anxious, and I could see that probably she's going to slip into panic attack at any moment. So these small observations made me to think of Calcarea carp in her case. Right? Now, the question is that we have the remedial understanding. So, is it just done that we give remedy to this patient and that's it? Well, Hahnemann has mentioned specifically about identification of exciting and maintaining causes. Let's not forget that. And for dealing with the exciting and maintaining causes and identifying them, if something comes to our health, or to refine our understanding about it, is the concept of psychiatric formulation that we have today, right? So the psychiatric formulation is basically a clinician's compass. It is a guide. It's a guide to how you'll plan the intervention in such complex cases. What is it? So it is basically the careful integration of patient's data in the framework of etiological factors with respect to the biopsychosocial model. Okay. Once the etiological factors in terms of 4 P's, that is the precipitating factors, the predisposing factors, the perpetuating factors, and protective factors are identified, then we are in a good position to formulate a cohesive and a holistic treatment plan for these cases. So how do we do that? We do this psychiatric formulation by using, of course, our DSM diagnostic criterias and applying various psychodynamic theories, cognitive theories, diathesis stress model, biopsychosocial model to the data that we have, interpreting the data in the light of these concepts, and that's how we figure out the formulation. Why do we do that? The purpose is to identify, of course, exciting and maintaining factors. Out of that, also the purpose is to find out what factors you can modify to what extent, which are the unmodifiable ones to what extent, and then accordingly identify the interventions needed, and not just identify them but also to gauge the favorable time and circumstance of introducing or removing any intervention. Okay. So we stop here today for the part 1, and how we are now going to use this psychiatric formulation and how we are going to manage this case in totality will be dealt with in part 2. So thank you so much for watching. See you in part 2. Signing off, Dr. Ananya Chitale.